Complications of otoplasty. All otoplasty approaches carry a risk of complications such as infection, hematoma, delayed healing or skin necrosis, chronic pain, suture extrusion, and problems with scarring. However, in the hands of an expert surgeon, these risks are likely to be low, and the early and long-term outcomes for both suture-based and cartilage-based procedures are often excellent. Complications. Asymmetry. Asymmetry may exist before surgery. If asymmetry occurs postoperatively, correction may be avoided if it is minor. Revision surgery is indicated if the asymmetry is annoying the patient. Bleeding and hematoma. Surgical intervention is necessary to control bleeding vessels and evacuate blood clots. Failure to remove an expanding hematoma in a timely fashion may result in tissue necrosis or chondritis. Cartilage irregularities. Mostly caused by full-thickness cartilage incisions or some sculpting techniques that weaken the cartilage. Cartilage necrosis. The necrotic area should be excised, may need secondary reconstructive procedure. Chondritis and perichondritis. Chondritis may require drainage and debridement of infected cartilage. Appropriate perioperative antibiotics and drainage of any collection of serum or blood can prevent chondritis. Overcorrection. Overcorrection of the middle third of the ear results in prominent inferior pole and contributes to the telephone deformity. Overcorrection of the superior and inferior poles results in the reverse telephone ear deformity. Obliteration of the external ear canal. This may result from setback of an extensively hypertrophic conchus with conchomastoid sutures alone. Treatment requires excision of the undercorrected conchus. Pain. Excessive postoperative pain may be a warning sign of a developing hematoma. The dressing should be removed and the wound examined for hematoma. Exploring the wound and evacuation of the hematoma may be indicated. Recurrent deformity. Recurrence of the initial ear deformity may be caused by trauma, patient manipulation, insufficient cartilage weakening, suture failure, or suture insufficiency. This may be the result of relying on skin excision to retain correction. Scarring. Baker and Converse reported hypertrophic and keloid scars in 11% of African American ears and 2.1% in Caucasian ears. About 80% of hypertrophic scars will resolve without treatment, but 80% of keloid scars will recur. Suture extrusion. Extrusion of sutures may result from permanent sutures being placed too close to the skin and excessive tension of the cartilage. Infection can cause sutures being extruded. Undercorrection. Undercorrection of the superior helix and lobule results in a relatively prominent superior third of the ear called the telephone deformity. Undercorrection of an overdeveloped conchal bowl can result in a reverse telephone ear. In summary, postoperative infection could be prevented by peri- and postoperative antibiotics. If developed, incision and drainage, cultures, and sensitivities should be carried out. Postoperative hematoma might be prevented by bolster dressing, xyroform gauze, head wrap, however evacuation and hemostasis treats well-developed hematomas. Intraoperative hemostasis and post-operative pressure dressing would prevent perichondritis/perichondral hematoma. Careful dissection, adequate approximation of the wound edges and wound care prevent wound dehiscence. Traumatic manipulation may lead to tissue necrosis, however using atraumatic techniques, wound care, hyperbaric oxygen may improve the situation. External auditory canal perforation can be prevented by careful dissection, however, if happened, primary closure with absorbable sutures should be done. External auditory canal stenosis may need revision surgery for correction. Elliott divided unsatisfactory results of otoplasty into early complications including pain, bleeding, hematoma, infection, pruritus, chondritis, and necrosis. Late sequelae in the form of residual deformity, unsightly scarring, patient dissatisfaction, suture problems, dysesthesias. Careful case selection is critical and is never more important than when the deformity is a minimal or subtle one. The same careful case selection is important in patients who have previously undergone one otoplasty and are dissatisfied with the outcome. The surgeon must be alert for the occasional adult who magnifies the severity of a small defect or who sees serious deformity in ears that others would judge as normal. Contraindications for otoplasty. There are very few contraindications for otoplasty. If a child begins to misbehave or becomes excessively worried about even going to the doctor for a preoperative discussion or going to the hospital, it is best to delay the surgery until the child openly requests the procedure. Other contraindications are a history of chronic otitis media, otitis externa, or conditions such as scalp infections or acne must be treated well in advance of surgery. A simple surgical wound infection can lead to an ear-threatening chondritis. Revision otoplasty. Not every otoplastic procedure will accomplish the desired result. One of the worst problems in revision otoplasty is cartilage destruction, tissue thickening, and contraction caused by postoperative perichondritis. Secondary procedures are therefore very difficult to make and require a proper understanding of the deformity and a sound knowledge of the surgical possibilities. Revision otoplasty is not one type of surgery but a number of techniques designed to improve the ear's appearance. It does not aim to reverse the original otoplasty, as in nearly all cases this is not possible. However, it will address the specific problems and set objectives that can improve the ear appearance. Inadequately applied otoplasty procedures may result in new deformities that need to be corrected, including an obliterated postauricular sulcus, sometimes known as glued-on ear, contour deformities of the antihelical fold, a telephone ear deformity, a protruding lobule, an obliterated external ear canal, and postperichondritis deformity. An obliterated postauricular sulcus can be rebuilt by a posterior zigzag skin incision, approximation of the skin triangle points, and filling of remaining defects with full-thickness skin grafts. Small irregularities or a sharp antihelical vault are best treated by curettage, through a small incision at the ear lobe or the superior crus, depending on the location of the irregularity. If the tissue loss or a sharp edge of cartilage along the anthelices is disfiguring the ear, undermine the skin to create a pocket and insert either temporalis fascia or cartilage from the conchus of the same or opposite ear. The best way to correct the obliterated external ear canal is by cartilage resection using a postauricular approach. Telephone receiver deformity needs a total reoperation of the ear, freeing the postauricular surface. The necessary cartilage reshaping is done by a removal of cartilage or by increasing its tension. In the center of the ear, a pocket is created for the insertion of cartilage under the anterior skin to rebuild the destroyed antihelix. Conclusions.